Don't know much about the film star. What Sarah means is that the University Hospital of Coventry and Warwickshire has been filmed by a documentary called Hospital, which is currently airing on BBC Two on Tuesdays at 9 p.m. So episode 2 is next Tuesday, the 18th, and it focuses entirely on the Gynaecology department. So that is myself and my fantastic team. So I would please encourage you all to watch it. Anyway, carrying on with, so streamlining gynecology oncology pathways. The reason we decided to do this, obviously over time and pre-COVID, there were lots of kind of hidden gaps in the pathways, and it led to patients having extended prolonged pathways. I was a consultant gynaecologist in Glasgow for 11 years, and then I moved down to the University Hospital of Coventry and Warwickshire in February 2019. And I saw a little range of kind of different practices across the region. So at UHCW, we are a tertiary referral center, and we pick up patients from not just Coventry, but also from nearby South Warwickshire Foundation Trust and George Eliot Hospital. So together we cater for a population of just over 1.2 million. So, oh, my thing is not working.
If you just give a left click, double click and a wiggle, Smruta, it should come. That's it.
Oh, let me just, okay. So while I see the poll results, so to, what the reason we kind of introduced this was during COVID, pathways got even more kind of disintegrated, as it were, because a lot of clinics were not happening, a lot of theaters were not happening. And it was an intense period where, because of the lack of theater capacity and the poor attendance at MDT, because for some time we couldn't even get our virtual MDTs because of IT issues, we found that patient pathways were getting disintegrated and patient care was probably going to suffer, which we didn't want. So we decided collectively that the best way to do this would be to centralize MDT, and I'll talk about that in a few slides in the forwards, but also if we introduce new guidelines that were followed throughout the patch of Coventry and Warwickshire, and we then disseminated this to GPs and everybody who used these pathways, we would hopefully have a better streamlined version of this pathway. How are we doing, Sarah? Now we've got, 25%, we've got gynecology nurses, which is good, absolutely. This is for you. So these are like some of the issues. So we had problems with referral criteria for suspected cancer, different hospitals, different GP practices were referring patients. And during COVID, it got worse because patients who were referred as urgent were not really getting seen unless they were referred as suspected cancer. So a lot of patients were being referred as suspected cancer when clearly when you read the referral, it wasn't suspected cancer. They just needed to be seen urgently. For example, somebody with menorrhagia who probably was urgent because she was bleeding and needed a blood transfusion, but this was not suspected cancer. So referring her down the route of suspected cancer was increasing her anxiety, but also she probably wasn't getting the right treatment because people were ruling out cancer and discharging them back when really they should have been treated for heavy periods as well, but that wasn't happening. Then we also found that we could have produced more evidence-based pathways for management of our 2-week waits and other conditions, which were not suspected cancers, but required urgent pathways. We also decided that it was well time to update our guidance for care of cancer in the tertiary care level for people conducting 2-week wait clinics. And also for people who got diagnosed with cancer, we needed a more kind of systematic approach to how they were going to be managed and how they were going to be offered treatment, including breaking bad news, key worker support from clinical nurse specialists, counseling, etc. So this is just a second poll to see how much time you spend in gynecology. It's just out of curiosity, really. So I'm trying to suss out after this talk, how many of you will take something back to your places of work. And it'll be interesting if you put in the chat, if you think there is something in particular that you'll take back to your place of work that might help improve your patient care or even your communication between your teams, etc. Anything. Much appreciated if you put that in the chat, because I want this to be an interactive session. I get awfully lonely these days talking to screens. That seems to be all the time, you know, apart from when you're doing clinical work, you're just talking to screens. So yeah, talk to me via chat and Sarah will tell me what you've said. So looks like 50%, you know, of your time in gynecology. That's good. 22%, 11%. And for those who rarely spend time in gynecology, I'm sure this is something that you can transfer to whatever it is that you do more often as well. It's just to kind of tell you why we did this, how we introduced it, and what is it that we do. So this is the 2-week wait referral form. So what we did, we found that there were about 3 or 4 versions of a 2-week wait referral form that were being used by different GP practices. And it got really confusing because some of the forms had very little information and the GPs had to enter a lot of information. And some forms were very, very prescriptive, but really they were coming to the same hospital and the same clinicians. So it didn't make any sense to have 3 or 4 different versions of outdated forms. So we joined up, and between the 3 hospitals, we decided, the clinicians and the clinical nurse specialists kind of got together and decided what were the essential criteria for referral for gynecological cancer. So we have, you know, important cancers: ovarian cancer, endometrial cancer, cervical cancer, vulvovaginal cancer. And we added this last one for recurrence of cancer because the previous form didn't have this. And we found that recurrences could potentially be missed because they were going to the GP. Clearly, a lot of GPs don't really examine people for recurrences of cancer, so they didn't really recognize what was happening. Or sometimes they only had atrophic vaginitis and were being referred for recurrence. So we thought, well, if we see them on a 2-week wait pathway, they're quickly diagnosed, then we can either say, yes, you have a recurrence and we'll manage it, or we'll say, no, you don't have a recurrence and everything's done and dusted, women are reassured. For ovarian cancer, we have nice guidance. And basically, if you can read that slide, I hope everybody can read the slide. So it's about identification of women with suspected ovarian cancer. Now, ovarian cancer is not something that has good screening tools like cervical cancer. And therefore, most women with ovarian cancer present to us at later advanced stages. We would quite like to catch ovarian cancer as soon as possible. Yes, even now, we probably diagnose most of them in advanced stages, but the sooner you catch it, the more treatment you can offer in terms of surgery and chemotherapy in whatever order. So NICE has said that if a patient comes to a GP with symptoms of bloatedness, feeling full, pain, urgency, unexplained weight loss, fatigue, etc., change in bowel habit, then the GP should do a CA-125. If the CA-125 is high, then NICE guidance suggests that they should do an ultrasound scan to look for any pelvic abnormalities, example, ovarian masses, adnexal masses, or ascitic fluid. If they've got any of that, they should then be referred to a 2-week wait clinic. Now, in our hospital, we have a sonographer that runs parallel to a 2-week wait clinic. So we just say to the GPs, if you suspect ovarian cancer, i.e. you've identified ascites, or if they have elevated CA-125, please refer them without an ultrasound scan because we can get it done quicker and they will get a diagnosis in the clinic before they leave. In terms of endometrial cancer, we've added quite a few more criteria. Previously, it was just, well, if they have postmenopausal bleeding, refer them. However, postmenopausal bleeding is not as straightforward as just postmenopausal bleeding. So menopause is where a woman has been amenorrheic or has had no periods for an entire year of 12 months. So if they have intermittent bleeding every 3 months or so, that's not postmenopausal bleeding. That is perimenopausal irregular bleeding. The incidence of cancer in that group of women is quite low. Therefore, they shouldn't be referred as suspected cancer, or our cancer clinics would be inundated by women with just heavy periods. So the criteria were postmenopausal bleeding, not on hormone replacement therapy. So women who've been amenorrheic for more than a year and then start bleeding, but are not on hormone replacement therapy, yeah, by all means, that is one of the criteria for referral. If they have postmenopausal bleeding, but they are on HRT, the guidance from the British Menopause Society is first stop their HRT, because very often it is just HRT that causes them to bleed. If after 6 weeks of stopping HRT, they still continue bleeding, then they form, that's one of the referral criteria. A third one is where women are on HRT and have persistent bleeding after 6 months of starting HRT. So this was a new criteria that we added. And that was because we found that, especially during COVID, a lot of HRT preparations were not available in the UK because of Brexit and COVID, a combination of the two. And therefore, women had to go from one brand of HRT to another brand of HRT. And in the process, clearly, the type of estrogen and the type of progesterone they got was slightly varied to what they were used to. So you could have had a woman who was quite happy on her HRT for 5-6 years, suddenly changed over to another brand of HRT and started getting irregular bleeding. So we didn't really want to see all these women because we knew that that was the reason. So what we said was, if they have persistent abnormal bleeding after 6 months of starting HRT, and you'll see there's an asterisk over there. So the asterisk really is to point out to them that the British Menopause Society guidance says that the commonest cause for abnormal irregular bleeding when you change HRT is because they have inadequate progesterone. So they get estrogen, but a lot of these women need extra progesterone. And therefore, we then give additional guidance to how much extra progesterone they should give before referring on a 2-week wait pathway. Tamoxifen. This is a drug that is used for women with breast cancer. Tamoxifen is an estrogen antagonist, and therefore can increase endometrial thickness and can increase the risk of endometrial cancer. When they are on tamoxifen, they are completely amenorrheic. So if they have dysfunctional bleeding on tamoxifen, that is one of the referral criteria. Women with Lynch syndrome, I have a slide coming up on that, so I'll leave that for that. And then asymptomatic postmenopausal women. So this forms a fairly big group. So for example, a woman goes to her GP to say, I have abdominal pain. GP does an ultrasound scan, or one of the general surgeons does an ultrasound scan, and as part of it, they find incidental finding of endometrial thickness more than 8 millimeters. Now, if a woman has postmenopausal bleeding, the cutoff of endometrial thickness on ultrasound scan is 4 millimeters. If they are on HRT, it is 5 millimeters. But if they are asymptomatic, the cutoff is more than 8 millimeters. If it is less than 8 millimeters and they have absolutely no bleeding or symptoms, the incidence of cancer in these women is quite low. So previously we used to get ultrasound reports in asymptomatic women, incidental finding, ultrasound thickness is 4 millimeters, referred to 2-week wait clinic. We really didn't want that. So evidence suggests 8 millimeters should be the cutoff. So that's what we've introduced now. And we have found a big difference in the referral pattern of these women. With cervix, vulva, and vagina, I think you just have to say, if you suspect something, please refer. Because in the community, people don't see this that often. In fact, a lot of general gynecologists probably don't see a lot of these to detect what is normal and what is abnormal. Now, as part of that, we were getting a lot of referrals for young women with postcoital bleeding who had what is called a cervical ectopy or ectropion. Now, we know that the incidence of cancer in these women is low, and they were being unnecessarily put through the stress of thinking they have cancer when they had normal smears and a normal looking cervix, but it looked slightly red. So in the next slide, I will talk about postcoital bleeding and how to manage that and when to refer them as suspected cancer. I've talked about the other two. I think the other things we added on are on the right-hand side of the slide, whereby we've asked GPs to kindly give us information such as performance status. For example, if a woman has a performance status of 4, what are we actually doing her any good by bringing her all the way to the hospital during COVID in possibly a 2-man ambulance to have a chat with her to say, you may or may not have cancer. I want to put you on a couch, put your legs up, put a speculum inside, do a biopsy, but then you're really not fit enough for any treatment at all. So do you really want to have this done? A general practitioner should be able to have that chat and give us an idea of whether they think, A, patient, is she fit enough for very much? And 2, if the patient willing to? We sometimes have women who are 95 years old who come to the hospital kicking and screaming because they say, I've always said I don't want anything done, but they're still brought in a 2-man ambulance. It does not make sense to have these poor women come into hospital like this. Then we ask about mental capacity because we want to know whether we have to get, a mental capacity form signed. Do we need to get somebody with power of attorney? Because during COVID, clearly, a lot of them are not allowed to come with relatives, but we need to know what some of them have vascular dementia. They may remember one moment, another moment, they may not remember. So these are the things that we need to know. And obviously, is the patient going to be away? During COVID, that was pointless because nobody should have gone away anyway. So Lynch syndrome, I promised you I would tell you a little bit about Lynch syndrome. I don't know if many of you have heard about this. So Lynch syndrome is an autosomal dominant cancer predisposition syndrome. It's a genetic mutation of, it's called the MMR gene mutation. And it is quite rare. It's less than 2,000 cases a year in the UK. But why such a big deal? Because it has quite a high risk of associated cancer. So 25% of women diagnosed with Lynch syndrome will have associated colorectal cancer, and they will develop endometrial cancer within 10 years of the colorectal cancer. 40 to 50% of women with Lynch syndrome who have endometrial cancer will develop colorectal cancer. So as you can see, if you have Lynch syndrome, the incidence of cancer is really high. And therefore, if we know that you have Lynch syndrome, we would quite like to screen you. So we've said that these women can be referred on a 2-week wait clinic, not because they have cancer at that moment in time, but so that we can get them in the system to offer them annual screening with a transvaginal ultrasound scan and an endometrial biopsy from the age of 35. And if they are premenopausal, then they should be counseled to seek attention for persistent intermenstrual bleeding or irregular heavy periods. Some of these women will come and say to you, I just want a hysterectomy. Clearly, that is something that is part and parcel of counseling because a hysterectomy is still a major operation and has major consequences. I promised you I would tell you a little bit about postcoital bleeding. So remember, if it is postcoital bleeding in menopausal women, you treat it like postmenopausal bleeding and they will be referred on a 2-week wait pathway. So this guidance is applicable only to premenopausal women. And in premenopausal women, the prevalence of cervical cancer in postcoital bleeding is 3 to 5%. And the prevalence of cervical intraepithelial neoplasia. So this is what you would detect if the woman had an abnormal smear and you did a colposcopy and biopsy. So it's a precancerous condition, is 6 to 17%. However, only 2% of women seen in secondary care with postcoital bleeding have cervical cancer. The incidence of cervical cancer in postcoital bleeding is really, really small. And the younger they are, the rarer it is. Majority of cases are not due to malignant disease. In younger women, and nowadays, I would call anybody under the age of 50 young, you would do certain swabs to rule out infection. Chlamydia is the #1 cause of infection that causes postcoital bleeding. So we say that if somebody comes with postcoital bleeding, please do a high vaginal swab and a chlamydia swab before you think they have cancer. Second commonest cause is problems with contraception. The combined pill, the mini pill, the various coils, the implants, the long-term progesterone contraceptives, all these can play a little bit of havoc with hormones and can cause abnormal bleeding. However, if you examine them and you think, I'm not quite sure of the cervix, vulva, or vagina, please refer under a 2-week wait. And for practice nurses, we've always had to remind them that an abnormal looking cervix or postcoital bleeding is not an indication for a smear unless the woman is due to have a smear. So a smear would be done only if she's due for a smear. A smear is not a diagnostic tool. So if you see something wrong with the cervix, don't do a smear, refer. So this is just the guidance that we sent out to general practices and secondary care. We've had to go through a lot of hoops to get all these guidances introduced. So it's taken us literally from, I would think, from about April 2020 to March 2021 to get all these guidances approved because all the stakeholders had to be consulted And that involved not just the tertiary care consultants, but the primary care GPs and the commissioners as well. So it's been a long, intense process, but we are quite glad that we've got it, we've achieved it. But clearly, we are constantly getting feedback about this, and the aim is to look at this on an annual basis to see how we can improve it. So this just gives the GP some information about postcoital bleeding, but we also give them some helpful information about what to do with it. Yes, if we tell you this is not cancer, the woman is still coming to you with postcoital bleeding. So what can you do? So on the right-hand side, we've given them, on the left-hand side, we've said what to ask in history, but also on the right-hand side, we've told them what to examine for and how to treat it if all the investigations are normal. So the commonest cause is the drop in vaginal acidity. So common things that you can do is use such as boric acid suppositories or gels called Relacta gel or Balance Active gel. I used to have a colleague who used to say to women, you can dip tampons in live culture yogurt because actually that is as good as a probiotic. It's a bit messy. I personally would say use Relacta gel or Balance Active. But some women quite like to use natural things, so they can do that. We say refer as cancer, obviously, if you look at it and you see a mass or you think this is cervical cancer. If you use these treatments and the bleeding still hasn't settled, then refer on, but again, not as a suspected cancer, but to a gynecology clinic because they might just need cauterization under a local anesthetic. So this is about HRT. What happens if women are on HRT? And we saw a lot of this during COVID because of the problems I discussed earlier. So if you get persistent unscheduled bleeding, so what do you mean by unscheduled bleeding? So remember, you get two types of HRT. You get the HRT that causes a sequential bleed. So they have estrogen and progesterone, a bit like the combined pill, but this is hormone replacement therapy rather than the contraceptive pill. So they get estrogen, they get progesterone, they stop it, they have a bleed. If you are over a year of menopause, then you can have what is called as a continuous combined form of HRT. That is HRT that doesn't give you a bleed. So unscheduled bleeding is any bleeding out with where it's meant to be. So if you use the sequential HRT and they have bleeding outside the packet, when she's still on the pill, on the tablet, or if she bleeds when she is on a continuous combined form where she's not meant to have a bleed at all. And in most cases, you have to modify the progesterone that you give them in various ways. Either you give it orally, you can give it vaginally, or you can encourage them to have a Mirena coil, and then you just give them estrogen replacement using the Mirena coil for 4 years rather than 5 years. So for contraception, it's 5 years, but if you're going to use it for HRT, it's only licensed for 4 years. Any questions so far?
There is, Smruta. So we have, have you found the GPs to work in partnership? So basically, maybe that could mean how have you found the GP to work in partnership with yourselves to support this 2-week referral pathway? Has there been any challenges?
The fortunate thing was that we had to get approval from them before we could introduce it. Wow. So it did go back and forth quite a bit. This is, like I said, it's taken us nearly a year to get this introduced. It's gone back and forth between us and the GP partnerships and the secondary care colleagues. But I think that's where your communication is absolutely vital. It would not have happened if we just introduced it. They bought into it. We've asked for their suggestions and the tips about postcoital bleeding. They all agreed that these were not cancer cases, but they all said, well, we need some guidance about it. So that's what's brought all this into play. And I'm very grateful for that. So I found we've actually been okay. They've all bought into it. And what we've done is we didn't actually say, well, this is the date where everything else disappears and this form is introduced. We've had an overlap. So we introduced the new form, I think about March. And we've said that for the next 4 months, we will use any form that comes in. However, every time we have a referral on an old form, we send back the new form to say, this time we will accept it, but the next time, please use the new form.
So that's interesting. So how was it? So obviously it's been a true partnership, literally a partnership in a two-way, obviously street, so to speak, in getting this implemented. Has there been some kind of, so obviously to get, although the GPs are on board, every member of staff that's linked to both primary and secondary, has there been sort of a rollout, or has somebody led on it, or how has it been?
So we've got the Coventry and Warwickshire Health Partnership sector, and we've got 3 women, fantastic women who lead this. But also they organized educational sessions for me to do, like I am doing today.
Okay.
I have done 2 or 3 educational sessions around North and South Coventry and Warwickshire. I routinely get questions from GPs, so I'm quite approachable. I put my email out there and I say to them, if you've got any questions, email us. We also have a route called advice and guidance, where the GPs can write to us and say, can I please seek some advice on this? It's actually working really well.
It sounds like it's from the partnership to the implementation and the delivery. It seems like it's been an absolute dream, which is fantastic.
I think it's because we've done it as a partnership. I think that was vital.
Yeah, that's brilliant. There is a couple more, but whether you want to leave them towards the end.
Why don't we leave them at the end?
Yeah. Brilliant. Okay.
So next step of the talk is what happens after we get this 2-week wait referral form. So we've got a referral as a suspected cancer. What happens? So at Coventry and Warwickshire, triaging is done by 4 gynaecology consultants. In South Warwickshire, it's actually done by 2 clinical nurse specialists. And in Nuneaton, it's done by their gynecology lead. So it just goes to show that you don't have to have a gynae-oncology consultant to do this. You just need somebody with appropriate knowledge. But the fact that we've made the 2-week wait referral criteria so clear, it's very easy for anybody who's got some degree of clinical knowledge about gynae-oncology to do it. So it can be done by nurses, clinical nurse specialists as well, and they do a fantastic job of it. Once we say, so the thing would be, yes, we accept this for a 2-week wait referral, in which case we say, will we do it face-to-face or a telephone? And we put that into the referral thing. If we say there's not enough information, we say refer back to GP, but we also give guidance to the GP to say, this is why we have not accepted this referral. Please refer back with this information. Or for example, occasionally we still get the postcoital bleeding. We'll attach the guidance of the postcoital bleeding and say, please follow this, but please contact me if you disagree, because there may be something here that I've not read. So it's a fairly approachable fashion that we do it in. Now in UHCW, we also have separate postmenopausal bleeding clinics, which means that it's a one-stop clinic. The woman comes in, she has a scan. If she needs a hysteroscopy and a biopsy, it all gets done at the same time. Some of the hospitals haven't got that set up yet. So these women will still come in as part of a routine 2-week wait and will have an ultrasound scan and come back for a biopsy, which we are trying to shorten. But there are logistics of clinical space and equipment in terms of the hysteroscopy stack, telescopes, staff training, recovery areas, etc., which are being worked on. And like I said, if we do reject a referral, we always give the GP reason and advise accordingly. So coming to the first part of the referral, suspected ovarian cancer. So when we get somebody with a suspected ovarian cancer, if you remember, I said we ask for a CA125, which is a tumor marker. Now, a CA125 is not a specific tumor marker for ovarian cancer. So if your CA125 is high, it does not mean you have ovarian cancer. It just means there's something abnormal going on that needs to be investigated. We do an ultrasound scan and we have a scoring system on the ultrasound scan. And as you can see, we score 1 point for each of the characteristics of how the ovaries look. So do they have cysts? How many cysts? Have there got any solid areas? Is there any ascites? Is there any evidence of metastatic disease, etc.? So you score from, if they have 0 to 1 points, the score is 1. If they have 2 to 5 points, the score is 3. So if you go on the top there, you'll see something called risk of malignancy index. So the U score could be 1 or 3. The M score is a menopausal status. So if they are premenopausal, the score is 1. If they're postmenopausal, that is, they have been amenorrheic for an entire year, the score is 3. So the M is equal to 1 or 3, and the CA125 is the actual CA125 result. And that is called a risk of malignancy index. A risk of malignancy index over 250 is high and then warrants further investigation for suspicion of ovarian cancer. So what we would do is arrange a CT of the chest, abdomen, pelvis, and take it from there. Now, this slide is to just remind people that CA125 can be high in various other conditions. Now and again, we get GPs who refer women saying, you know, they've gone to them feeling some abdominal bloatedness. GPs examined them, found tons of ascites in the belly, done a CA125. CA125 is 500, 600. Normal CA125 is 35, but has not remembered that the woman has got cardiac failure or severe bronchiectasis or has ongoing breast cancer that she's getting treated for. So like you can see, there are other cancers that can cause CA125 to go up. There was a study called UK CTOX, which was looking at the possibility of using ultrasound and CA125 for screening for ovarian cancer in menopausal women. And as part of that study, they found that there was a significant proportion of women who had elevated CA125, but normal ultrasound scan of the pelvis. And when we did the CT scan, they found a lot of other cancers, pancreatic cancer, GI cancers. So other cancers can also increase CA125. In younger women, the one thing that does increase CA125, and it rises to fairly scary figures of 500, 600, is endometriosis. Severe endometriosis can put your CA125 up really, really high. Other organ abnormalities, cardiac failure, ascites from liver cirrhosis. A woman's got history of chronic alcohol consumption, severe pelvic inflammatory disease, severe diverticulosis. So any inflammatory condition can put your CA125 up. Pregnancy can increase your CA125 as well. Any questions so far on suspected ovarian cancer?
No, not at the moment.
Okay. I'll remember we've got lots of time at the end. So the next part of the 2-week wait pathway was suspected endometrial cancer. So if you have a woman who's been sent as suspected endometrial cancer under those 6 categories, if you remember, so, you know, bleeding without HRT, unscheduled bleeding on HRT, Lynch syndrome, tamoxifen, or incidental finding of endometrial thickness over 8 millimeters. So firstly, examine these women because there could be a non-uterine cause just by examination. So they could have vulval, vaginal, cervical causes. There could be trauma. We have seen a few cases where there has been trauma from piercings from the partner that could have caused this. So yeah, examination is vital. Don't jump into an ultrasound scan directly. Then you do an ultrasound scan. A transvaginal ultrasound scan is much better because they don't need full bladders and you get a much better picture of the pelvis. Endometrial thickness. So if they are not on HRT, the cutoff is 4 millimeters. If they are on HRT, the cutoff is 5. And if they are asymptomatic, the cutoff is 8. We will do an endometrial biopsy. It's called a Pepel endometrial biopsy. It just looks like a little straw. It goes through the cervical os and we just get a little bit of tissue. The pain is very similar to a severe cramp that one might get during a smear test. If we find that we don't get sufficient material on an endometrial biopsy, or if the ultrasound scan suggests that there is something inside the uterus, such as a polyp or a fibroid, we would do a hysteroscopy. Now, if all these investigations are normal, the first time around somebody has postmenopausal bleeding, we will say everything's normal, discharge. However, we do give advice to say if this bleeding continues, despite all the investigations being normal, please refer back again, because sometimes women will have fallopian tube cancers where endometrial biopsy will be normal, ultrasound scan will be normal, because until the fallopian tube increases to quite a large size, you're not going to pick it up on scan. And clearly a hysteroscopy is going to be normal because a uterine cavity is going to look normal because the abnormality is in the fallopian tube. So we do discharge them with advice to be referred back again into the system if they keep bleeding. A lot of these women will have atrophic vaginal mucosa. So when we discharge them, we do give them some estrogen replacement vaginally, and that usually resolves the issue. Any questions so far?
There is another, well, there is a few, but there's one in particular, Smruta. There was a decline in uptake for cervical smears before COVID in younger women. Has this got worse? And are you seeing more later stage CIM because of it?
So we didn't see a reduction in uptake, but what we did see was the cervical screening program stopped quite abruptly during COVID for quite a few months. I think everybody was kind of unsure of what to do and nobody wanted to see anybody face to face. So the cervical screening program did stop abruptly for, I think, 2 to 3 months and then picked back up again. We haven't, anecdotally, yes, we've probably seen 1 or 2 cases of cervical cancer that are quite advanced, but on average, I wouldn't say we've seen much more advanced cervical cancer. However, we've been inundated with increased referrals to colposcopy because all those women who didn't have smears for those 3 months suddenly came along with the women who were meant to have their smears in that time. So we have had absolutely dramatic increase in our referral to colposcopy, more so because the cervical screening program has now changed in that we no longer are looking for smears only, we are looking for high-risk HPV. So if somebody has a high-risk HPV on her smear, but still has a negative smear, and she has 2, 3 of those consistently, she will be referred for a colposcopy. So we've got a combination of reasons why our colposcopy referrals have gone up, and hopefully that will settle down in the next couple of years.
Okay, so hopefully it will balance eventually. Yeah. Okay. Thank you, Smruta. We'll leave the others till I'll let you carry on.
Okay.
Yeah.
So I mentioned about centralizing MDT. So our first centralized MDT happened on the 9th of April. So just very recently, as you can imagine. So just to give you a bit of background, prior to this, what was happening was, so UHCW is a tertiary referral center. So we had a big MDT every Friday afternoon that lasted for about 2 to 3 hours. And in an MDT, you have a radiologist, a pathologist, oncologist, gynaecology surgeons, clinical nurse specialists, all sitting together and making decisions. If you remember, I said we also take referrals from Warwick and we take referrals from George Eliot Hospital. These places had their own independent MDTs first. At that MDT, they would discuss this case. Then the decision would be made to refer her to the UHCW MDT, and therefore, there could be a delay of at least 1 to 2 weeks before the patient actually got a final plan. Now think of a case scenario. A woman has come in, she's maybe 50, 55, suspected ovarian cancer. You do an ultrasound scan and you find she's got lots of ascites and her CA125 is about 1,000 to 2,000. You do a CT scan and it shows, advanced ovarian malignancy. You do this at one local MDT, and then you think, well, I need to put her through a centralized MDT. So a week later, she goes on a centralized MDT. The centralized MDT looks at this. Because you didn't have a clinician or anybody representing her from the previous hospital, if we don't have enough information about her fitness, we say to them, we can't give you any outcome because we don't know her story. Please come back next week. That's another week's delay. We get the story, then we say, let's do a biopsy because she's not suitable for surgery. The biopsy can take another 2 weeks. Then we get the result of the biopsy that's brought back to the MDT. At the MDT, we say, okay, this result is not sufficient for diagnosis. So then we need to do a laparoscopy. So think of the time that has been lost between her first MDT to when this poor young woman actually starts her oncology treatment that she should have started. And this was becoming quite, during COVID, this got quite bad because of just, everything just came to a standstill. And it was twice as hard to find slots for scans, biopsies, etc. Also, we found that if the woman got discussed at the MDT, there was a little bit of, nobody was clear as to who would actually tell this woman what the outcome of the MDT was. It wasn't clear who was going to action it. Was the local clinician going to action it? But the local clinician wasn't at this MDT. So who is going to action this? So all in all, we decided this is, ridiculous. Patients are suffering. Let's make it quicker. Let's all work together. We all get along quite well. Why don't we just speak to each other in one common platform? So we introduced network guidance first. We agreed the network guidance the same way we agreed the 2-week wait pathway. Everybody bought into it. And then we said, we will centralize MDT. So there will no longer be localized MDTs. Everything will come to the centralized MDT. Well, everybody panicked because they thought 2 hours at a centralized MDT. Before was it was 2 hours. If we bring all these patients, this is going to be like a whole day of MDT. Clearly, nobody can cope with 8 hours of MDT. So we had to then introduce strict referral criteria into MDT. What is it that actually needs an MDT? If somebody's got a pelvic mass and a normal CA125, the risk of her having malignancy is very, very low. If her risk of malignancy index is less than 200, her risk of malignancy is really low. Does she need to come to MDT? No. There is guidance out there from the Royal College of Obstetricians and Gynecologists to say this is what she needs. If a woman has postmenopausal bleeding and her endometrial thickness is less than 4 millimeters, or her biopsy is normal, does she need to come to MDT just to confirm that? No, because there's a guidance out there to say what you need with this women. MDT should be only for women with cancer who need complex decision-making, not for simple decision-making. And that way, again, everybody had to buy into this. We introduced quite strict referral criteria. So now what happens is at the local hospital, there is one consultant and designated clinical nurse specialist who sits together every week just prior to Wednesday. Based on this referral criteria, they decide what decisions they can make locally. And then 1 or 2 patients are then referred on to the centralized MDT. I say before Wednesday because Wednesday 2 p.m. is the cutoff so that we can have these patients ready for discussion on the Friday at 1 p.m. This has been going on since the 9th of April. So we've had now about 4-5 MDTs. It's running slightly over 2 hours. So we now finish, instead of 3 p.m., we're still finishing at 3:30 p.m. But a lot of that is because everything is on Teams and things crash quite frequently when we are sharing screens with complex CT scans and MRI scans and complex pathology slides, and going back and forth between the MDT outcome form that everybody needs to see and verify and authorize. Hopefully, as COVID becomes less, dare I say it, we will go back to rooms, and we will have a hybrid system where those people who want to do it remotely can link in, but people can be in the rooms. The radiologists much prefer being in the room because they have a good system and they can project it quite nicely without having to worry about something crashing every time they share a screen. A single MDT is one decision making. All the clinicians come to it who are responsible for patient care, and therefore there's none of this confusion about, oh, we don't know anything about this patient. We avoid repetition and we avoid confusion. The patient pathway is a lot quicker. We've had extremely positive feedback in the last 4 weeks. Not only that, it has proven to be really educational. So the district general hospitals, I don't think had realized how complex cases we deal with. I think they have a lot more respect for the MDT now because they see the complexity of cases and the intensity of discussions, shall I say. There's never blood on the walls, but there are quite intensive discussions, and we all root for our patients. Everybody wants what is best for patients. And as a clinician, that is my job. I am fighting my patient's corner. I am putting it through the MDT that, she's got this. I think this is what she needs, but obviously it needs to be an MDT decision. So yeah, a few issues just now, but I'm pretty certain, I'm confident we'll iron these out. And as time goes on, things will only get better. It is also a huge educational opportunity for trainees, other consultants, for GPs, anybody to link in, just to understand how we work with gynecological cancer. I often find a lot of people just prior to their MRCOG exams linking in. Okay. So remember, at the start, I said, I quite would like to know how you would share this knowledge at your place of work. How would you use it? Would you use it for something else, but use what you've taken from today? What have you taken from today? Talk to me. So I think we're just going to have a word cloud there of what you kind of just give us some words. I like word clouds.
So far, Smruta, we have got, I know you can see some of the words there for the word cloud, but I can also see this end, the actual amount of votes. The team meetings is a very big one. Mm-hmm. So I think I'm taking that as they would like to share the content that you've delivered today, especially probably the 2-week wait referral, team meetings, case report presentation. I'm just quickly looking here.
Yeah. I mean, if anybody wants to contact me by email, please do, just to kind of share what we did and how we did it, if that's what you want to do.
If anybody else would like to submit, please do so. Because Smruta would love to hear how you can share the content that she's just delivered.
I've had such positive feedback from not just, primary care, but my own trainees, because, and my general gynecology colleagues, because we all deal with different specialties. So just as I probably no longer remember what to do in obstetrics, well, I do a little bit, but not really great details of it. My obstetric colleagues probably don't remember very much of how to deal with gynecological cancer. If I'm dealing with, say, IVF and infertility all the time, I probably don't know whether a pelvic mass is benign or malignant. So it's quite nice to have guidance there. And yeah, it's made things so much better for my trainees and my colleagues. And I'm getting really good feedback from this. It is work in progress. We'll have to keep working on it.
Absolutely, and I think this is exactly the reason why we're here today, for sharing best practice, because this is just fantastic to hear the amazing work you and your team are doing. Just something you highlighted, which is something that's well, clearly a hot topic out there. The MDT that obviously that's gone out. You mentioned a huge education opportunity for trainees, which obviously is something there's been a big focus. And I know we alone hosted an event for surgical trainees and medical students, because they've had a huge impact over the last 12 months. So there's another great opportunity.
Absolutely.
I think that's probably all we're going to get in for now, Smruta. So I can, that's just come in. So we have some questions. So, I mean, we've obviously answered 2 or 3 already, Smruta. So, I mean, thank you so much for sharing the amazing work you and your team are doing. And we keep saying, obviously, the key words, sharing the best practice. And if this can help other areas, that would just, well, it was truly awesome. So I think that speaks volumes. That last comment that's come in, this is fantastic. Absolutely.
Thank you.
The question here is, the 2-week referral clearly demonstrates benefits to the patients. What have you found to be the biggest benefit to any one patient?
The reduction in the time. Do you remember I said they got discussed at one MDT, then they got discussed at another MDT, then it went back to them. It was unclear who was going to tell them what was happening. I think that is the one thing, and that was absolutely the primary goal, was to reduce the time spent on the patient pathway.
Yeah.
Especially now we are obliged to do what is called as a faster diagnosis. So within 28 days, we have to give them their diagnosis.
And I think going back to the centralised MDT, it was interesting when you said, when you launched it the 9th of April, obviously there was going to be challenges. You had your team, the teams, the obviously going down the Wi-Fi, whatever it may be, and the screens and the amount of information, content you had to the files you had to share. But again, it comes back to that word of reflection, how we need to adapt. And you've obviously made further changes, and that hopefully will develop even more when, fingers crossed, you can go more face-to-face and progress even more.
I think the main thing was we all forgot we were on mute. So we would do a spiel for 5 minutes before somebody said, you are on mute.
Yeah.
So it's like, here we go, talk for 5 minutes again.
Yeah, so there's the time for, absolutely. We've all done that, I'm sure, over the last 12 months. There's no doubt about that. Another question here that's come in, has the backlog over the last 12 months, I suppose this can be looked at different ways actually. So has the backlog over the last 12 months been reduced at all due to this new pathway?
We're certainly finding that we are triaging, unfortunately, ones that have already been triaged, we can't go back and change that triage. It won't be fair on the patient or the GP. But what we are doing is we're certainly triaging them a lot better now, because we have this new pathway in place. So whether it's the clinical nurse specialist or a consultant looking at it, the triaging is hopefully consistent, more or less, into what is being accepted and what advice is being given. what I did do is I encouraged GPs to send in what I said was advice and guidance. So this is just the GP writes to the hospital via this advice and guidance route to ask for advice on whether they should refer or what they should do. And I absolutely encouraged GPs to do that. And yes, it is very time consuming, but it has been totally worth it because we are now engaging much better with primary care. And we are finding that a lot of referrals coming through now are referrals that should be coming through.
Okay, so that's absolutely reassuring to hear then, isn't it? Absolutely, absolutely. Okay. Another question that's come in here is, although it is still early days, what effect has this had on the patients you do now see as a result of the central MDT?
Again, faster diagnosis. So I'll give you an example. There was a young 28-year-old girl who had surgical management of miscarriage that had failed medical management about 3 weeks ago. And when she had her surgical management of miscarriage, the general gynecology consultant who examined her found some suspicious cystic lesions in her vagina. So he biopsied them as you would. And the local pathologist in the DGH said this was rhabdomyosarcoma, which is an extremely rare, horrible, aggressive cancer. Now, she is 28. She's had 2 miscarriages. She doesn't have children. And, here we are with somebody diagnosing a horrible, aggressive cancer that has huge implications on her life. When I saw, so basically she got discussed at the MDT when we got the pathology result on Friday last week. And we decided that we would send this for a specialist opinion to a specialist pathologist in Birmingham who does very complex, unique gynecological cancers. Whilst awaiting that, I said, why don't I see her on Monday? Because this would be 3 to 4 weeks after her miscarriage. I saw her on Monday. I have now seen her. I've counseled her. I examined her, and I couldn't find any more cystic lesions. So I'm a gynecologist, so I have much more expertise in this area than a general gynecologist who does obstetrics. So me seeing her, just examining her and reassuring her that I haven't seen anything nasty was obviously, it helped her, to some degree. On Friday, we asked for the pathology result. Just today, I've had an email, and that pathology from Birmingham has confirmed that this is just pregnancy-induced benign changes.
Oh, wow.
So in the old days where we didn't have centralized MDT, she would have got discussed at this Monday's MDT when we got the pathology, the first pathology back saying it's a horrible cancer. Then she would have got discussed at this week's Friday MDT centralized. And we would have then said, so after a week, we would have said, refer it to Birmingham. The Birmingham result would have come next week. She would have then got discussed at the Friday MDT the following week. And all this time, this woman would have sat at home and worried to death. Does that help you give things in perspective?
Hopefully that's answered the question, whoever sent that in. So hopefully, yeah. I was going to obviously thank you for, this last comment that's come in was basically said what I was going to finish off with, actually, Smruta, which is, it is so fascinating to hear. And I'm sure everyone watching will agree to hear the fantastic work you and your team are doing, and the outcome and the positive patient outcomes and how this is benefiting the patients. But I think the partnership for the primary and secondary care stood out here more than anything. It truly is inspirational. So I'm hoping.
Yeah, it is absolutely vital to do that. Without the partnership between primary, secondary, and tertiary care, you just can't do it. And people have been so, cooperative because we all want the best for our patients. GPs have been absolutely fantastic.
And this is just come in now. I'm just putting it through.
Thank you very much.
That's so that's a lovely comment, and that's just come in now. So watch
us in action next Tuesday.
Yeah, absolutely. Do you know what? I keep saying it, but that really has been truly inspirational, and I'm hoping that people that have been watching have been taken a lot from this, Smruta, and yeah, definitely get watching next Tuesday, Smruta, Hannah team.
you.